Here's a question I want you to sit with for a moment. What if the process slowly narrowing your arteries began long before you had any idea something was wrong? Before your first blood pressure reading, before your first cholesterol panel, possibly before your children were even born? No chest pain, no warning sign, no flicker on the dashboard, just quiet, invisible buildup that spent decades going completely unnoticed. That's not a hypothetical scenario. That's what cardiovascular disease actually does, and it's exactly what we're talking about today. I'm going to walk you through two specific foods, backed by peer-reviewed, published clinical research, that have shown a genuine ability to physically reduce arterial plaque. Not stabilize it, not slow it marginally, actually shrink it. And if your cardiologist has never once mentioned either of these, I'm going to explain exactly why that is, because the answer matters. If this is the kind of content you've been looking for, real cardiovascular science explained clearly, the kind of conversation that simply doesn't happen in a 10-minute appointment, hit subscribe right now. I put out new videos every single week, and I promise you will not want to miss what's coming up. Let's start with something that genuinely rattled me when I first confronted it. And I don't rattle easily after decades in this field. About 3 months before sitting down to record this, I found myself alone in a quiet room staring at my own carotid artery scan. I've performed thousands of cardiac procedures. I've stood over operating tables for hours. I've seen what advanced arterial disease looks like up close in a way most people fortunately never will. And there it was on my own scan, plaque. Not catastrophic, not requiring emergency intervention, but unmistakably present. Sitting there like an uninvited house guest who'd settled in so gradually no one had noticed them move in. The thing that struck me wasn't fear, it was honesty. If I, someone with 30 years of clinical experience, access to the best cardiovascular imaging available, and a professional obligation to understand this disease, could have plaque quietly accumulating in my own arteries without any symptoms, what does that say about what might be happening in yours right now? I knew exactly what the standard playbook looked like. Monitor it, prescribe a statin, schedule a follow-up in 6 months. I've written that exact plan for hundreds of patients, but this time it was my scan, my arteries, and I decided to look further. What followed over the next 3 months genuinely surprised me, and I think it will surprise you too. But before we get there, let me explain what's actually happening inside an artery, because most people picture plaque entirely wrong. The common mental image is something like grease coating the inside of a pipe, thick, gunky, the kind of thing you'd expect a good salad to flush right out. I understand why that image sticks. It's intuitive. It's also almost completely wrong. Your artery wall is more like the lining of a garden hose, flexible, elastic, built to handle constant pressure and movement. When that wall sustains damage, from high blood pressure, from smoking, from chronic low-grade inflammation, your body immediately dispatches a repair response. That crew includes LDL cholesterol, immune cells, and a structural protein called fibrin. Fibrin doesn't just patch things loosely, it forms a rigid internal scaffold. And everything else, the cholesterol, calcium, dead cellular debris, gets packed tightly inside that scaffold. Think of it like concrete being poured into a rebar frame. What you end up with isn't a soft, greasy blob that could dissolve with better eating habits. It's a hardened, architecturally organized structure with a fibrin skeleton at its core. That is what a mature arterial plaque actually is. I want you to remember that, because it changes the entire conversation about treatment. Now here's where the real complexity begins. LDL cholesterol by itself isn't even the main aggressor in this story. LDL becomes dangerous when it gets oxidized. Oxidized LDL is what triggers the inflammatory cascade that starts this entire destructive cycle. And here's the part that doesn't get nearly enough attention. After 60, your body's natural antioxidant defenses are substantially weaker than they were at 40, so oxidation accelerates, damage accumulates faster, plaque builds faster. You're not just dealing with one problem, you're dealing with 3 separate mechanisms working together simultaneously. Oxidized LDL striking the match, chronic inflammation keeping that fire burning continuously, and a fibrin scaffold locking all of that damage into a permanent structural form. 3 distinct drivers, one very consequential outcome. And that raises a question I think deserves a direct, honest answer. If 3 separate biological mechanisms are fueling this disease, can a single drug category reasonably be expected to address all of them? Let's talk about statins. Honestly, I've prescribed them. I will prescribe them again for the right patient. Statins are real, evidence-based medicine. They lower LDL effectively, they reduce cardiovascular event risk in high-risk individuals, and that is well-established science that I'm not questioning. What I am pointing out, because almost no one says this part clearly, is what statins do not do. Statins lower your cholesterol numbers. They do not physically dissolve or meaningfully shrink existing arterial plaques. This isn't my opinion. Study after study confirms it. Even the most aggressive statin regimens produce plaque regression measured in fractions of a millimeter over a full 12 months. Changes so small they require specialized imaging to detect it all. The plaque stays. It just grows slightly more slowly. So when a 65-year-old patient sits across from me and asks, "Doctor, will these pills clean out my arteries?" the fully truthful answer is no, they won't. But that answer rarely gets spoken with that level of clarity. Patients leave the office feeling like the problem has been handled. In reality, it's mostly being decelerated. Those are two very different things, and patients deserve to understand the distinction. So is slowing the progression the ceiling of what's possible? Or is there something that actually reverses it? The fibrin scaffold is the key to understanding this, and here's the brutal irony of it. The same fibrin structure that stabilizes a plaque and reduces its risk of rupturing also makes that plaque almost completely resistant to cholesterol-lowering drugs. You could theoretically eliminate every LDL molecule from someone's bloodstream, and the existing plaque would remain entirely intact, because its internal skeleton is fibrin, a protein with no connection to cholesterol whatsoever. Statins reduce the supply of new material, but the mortar holding the existing wall together requires an entirely different approach. This is why, after decades of aggressive statin therapy, cardiovascular disease in people over 60 remains a true epidemic. Medicine got very good at managing one piece of the mechanism and largely left the rest unaddressed. Two questions kept pulling at me. What actually breaks down fibrin? And what prevents LDL from oxidizing in the first place? The answers led me to two compounds that most physicians, including myself, for most of my career, have never once discussed with a patient, despite the fact that the supporting research is published, peer-reviewed, and genuinely striking. Let's start with the first one. Researchers enrolled patients with documented carotid artery stenosis, confirmed measurable plaque narrowing in the neck arteries. This wasn't theoretical. These were real patients with real imaging evidence. One group received 50 milliliters of pomegranate juice daily. That's roughly 3 tablespoons. Not a glass. 3 tablespoons. The other group changed absolutely nothing. 1 year later, the pomegranate group showed a reduction in carotid artery wall thickness of between 17 and 30%. The plaques physically shrank. I want you to read that again slowly, because it's not a minor finding. The plaques got measurably smaller. Meanwhile, the control group's artery wall thickness increased by 9% over the same period. One group got meaningfully worse. The other drank 3 tablespoons of juice a day and got measurably better. That study was published in the journal Clinical Nutrition. This is not folk medicine. This is not a wellness blog. This is peer-reviewed clinical research. How does pomegranate actually accomplish this? 2 distinct mechanisms. First, it contains some of the most potent antioxidant compounds found in any food on Earth, specifically punicalagins and ellagic acid, which reduce LDL oxidation by up to 90% in measured studies. Cut off the oxidation and you cut off the primary trigger for new plaque formation at the source. Second, pomegranate enhances HDL function. HDL's biological job is to pull cholesterol out of existing plaques and transport it back to the liver for clearance. Pomegranate doesn't merely raise HDL levels, it makes HDL significantly more effective at performing that function. So you're simultaneously stopping new damage from forming while actively facilitating the clearance of what's already there. That's a meaningful two-front approach. One important note, not all pomegranate juice is the same, and I want to be specific because this matters. The sugar-saturated, diluted bottles sitting on most grocery store shelves are not going to deliver these results. What you want is pure, unsweetened pomegranate juice, 3 tablespoons daily, taken consistently over months, not days. That's what the research used. That's what produced the 17 to 30% plaque reduction. And I'll be honest with you, in 30 years of clinical practice, I never once had this conversation with a patient. Not once. Now for the second compound. I'll admit I was skeptical the first time I came across it, which is its own kind of irony given what I found. Nattokinase is an enzyme derived from natto, a traditional Japanese food made from fermented soybeans that has been part of Japanese cuisine for well over 1,000 years. Japan, incidentally, has consistently among the lowest rates of cardiovascular disease in the entire developed world. Researchers decided to investigate whether that was a coincidence. What nattokinase does is specific and mechanically direct. It dissolves fibrin. That protein scaffold holding your arterial plaque together, nattokinase breaks it apart. It's classified as a fibrinolytic enzyme, meaning its entire biological function is to dismantle fibrin networks, the exact same networks that form the internal skeleton of arterial plaque. A clinical trial published in the European Journal of Preventive Cardiology followed patients taking nattokinase at 6,000 to 10,000 FU daily for 26 weeks. The average plaque size reduction was 36% in 6 months. Compare that to the fraction of a millimeter regression produced by aggressive statin therapy over a full year. The difference is not subtle, but I need you to hear this part with equal seriousness. Nattokinase carries real blood-thinning effects. If you are currently taking warfarin, aspirin, clopidogrel, or any anticoagulant, and many people over 60 are, you cannot simply add nattokinase without first speaking with your physician. I'm not saying that as legal cover. I'm saying it because the drug interaction is genuine and can significantly increase bleeding risk. If you're on blood thinners, that conversation with your doctor is not optional. It comes first. Full stop. So why has none of this come up in your doctor's office? I want to be clear. This is not a conspiracy. Nobody is locking pomegranate juice in a back room somewhere. The reality is more mundane, and honestly, more frustrating precisely because of how ordinary it is. Medical guidelines are built around large-scale, expensive clinical trials, the kind that cost hundreds of millions of dollars to run, and those trials are funded predominantly by pharmaceutical companies, which understandably focus their investment on things they can patent and profit from. You cannot patent pomegranate juice. You cannot patent an enzyme that's been in Japanese kitchens for a millennium. So the massive multi-center trials simply don't exist for these compounds. The smaller studies that do exist, and there are more than most people realize, are easy for mainstream medicine to categorize as not yet conclusive because they haven't been replicated across 40,000 patients in 15 countries. Meanwhile, statins with exactly that kind of trial infrastructure get grade A guideline recommendations and land in every clinical protocol on the planet. That's not corruption. That's how medical funding flows. It's a systems problem, not a character problem. Add to that the reality of a 10-minute appointment. A cardiologist managing elevated cholesterol and early plaque buildup genuinely does not have time to step outside official guidelines and walk a patient through the biochemistry of Japanese fermented enzymes. Even when the research supports it, I'm not criticizing my colleagues. I worked inside that same system for decades. But understanding why this conversation doesn't happen isn't the same as accepting that it never should. And hey, if you're finding this useful, this is exactly the kind of content I put out every week. Subscribing takes 2 seconds, and it makes a genuine difference in helping this reach the people who need it most. Let's make this practical. For pomegranate, 50 milliliters of pure, unsweetened juice daily, or a standardized extract containing at least 30% punicalagins. Timing is flexible. Morning tends to work well because it anchors into a routine and you're less likely to forget it. The single most important variable is consistency over months, not days. This isn't a 2-week experiment. For nattokinase, the therapeutic range used in research falls between 2,000 and 10,000 FU per day. Most commercially available supplements come in 2,000 FU capsules, 2 to 3 capsules daily, taken away from meals for better absorption. And once more, if you're on any blood thinner, that's a conversation for your physician before you start, not after. Here's what I'd strongly encourage you to do. Get a baseline carotid intima media thickness measurement. It's non-invasive, involves no radiation, and is available at most imaging centers. That number becomes your personal benchmark. Objective, measurable, yours. Repeated at 6 months and again at 12. That's how you actually know whether something is changing inside your body, not just in a published study. Now let me explain why these two compounds together are meaningfully more powerful than either one alone, and why that combination represents a fundamentally different strategy than statins by themselves. Pomegranate and nattokinase work on completely separate biological pathways with no overlap. Pomegranate addresses the upstream problem. It neutralizes oxidized LDL before it triggers new damage, enhances HDL's ability to clear existing cholesterol from plaques, and suppresses the chronic inflammatory signals keeping the entire cycle active. Think of it as cutting off the supply lines. Nattokinase addresses the downstream problem. It enters the existing plaque structure and dissolves the fibrin scaffold from the inside, making the trapped material accessible for the body to clear naturally. Think of it as the demolition crew. One stops new construction, the other tears down what's already been built. That's a coordinated two-front strategy, which is something a single drug targeting a single mechanism simply cannot replicate. Meaningful results in research begin appearing around the 3-month mark. Significant regression typically takes 6 to 12 months of consistent daily use. For a condition that took decades to develop quietly, that's actually a remarkably short window. And crucially, you can verify it on imaging rather than just hoping for the best. Many people also report secondary benefits that emerge as blood flow improves. Lower resting blood pressure, better circulation in the extremities, improved energy levels. Those aren't the primary goal, but they're not unwelcome side effects either. Now let me bring this back to where I started. I was alone in that imaging room looking at my own scan. I made 2 decisions in that moment. First, I was not going to simply monitor and wait. Second, and this is the part that mattered professionally, I was not going to recommend a protocol to patients without first being willing to test it on myself. So I started pomegranate extract at the 50 milliliter daily equivalent. I added nattokinase at 8,000 FU, split into 2 doses taken away from meals. I wasn't on anticoagulants. I discussed it with a trusted colleague, and then I began. 3 months later, my carotid intima media thickness had reduced by 20 to 25%. I've seen things in operating rooms over 30 years that have genuinely moved me. But sitting in that imaging room, watching my own numbers move in the right direction by that magnitude, that was one of the most personally significant moments of my clinical life. Not because it was dramatic, because it was real, it was mine, and it confirmed what the published research had been pointing toward for years. I'll be the first to say, one data point is one data point. I'm a cardiac surgeon, not a randomized controlled trial. My personal result doesn't replace population-level evidence. But it does add a human dimension to a body of published research that already points in a compelling and consistent direction. How many patients over the past 3 decades left a cardiology office holding a statin prescription and a see you in 6 months, and were never once told that 3 tablespoons of pomegranate juice and an enzyme from fermented soybeans might actually reduce what was growing inside their arteries? I can only speak for myself. And the honest answer is, too many. Here's what you can do starting today. Talk to your doctor. Ask specifically about a carotid intima media thickness measurement. Ask about your LDL oxidation markers, not just your total LDL number, but whether your LDL is being oxidized and triggering inflammation. Ask whether your current treatment plan addresses fibrin accumulation and arterial inflammation, or whether it's focused exclusively on cholesterol. If those questions are taken seriously and answered thoughtfully, that's a good sign. If they're dismissed without engagement, that tells you something important, and it may be worth seeking a physician who takes the full picture seriously rather than just the piece that fits the standard template. Leave a comment below. Are you currently on a statin? Has your doctor ever discussed actual plaque reduction with you? Not just cholesterol management? I read comments and they genuinely shape what I cover next. And if this video explains something that nobody had taken the time to explain to you before, please share it with someone over 60 who needs to hear it. That small action reaches people I can't reach on my own. Before we close, I want to be direct about something. Everything in this video is grounded in published research and 30 years of clinical experience. But your body is not a research study. Your medications, your medical history, your individual risk profile, none of that is visible to me here. Before changing anything about your health routine, speak with your own physician. What I've shared today is education. What your doctor offers, with full knowledge of your personal history, is medicine. You need both. And neither one replaces the other. The research exists. The compounds are accessible. The protocol is clear. The only thing that was consistently missing was the conversation. I'm Dr. Brian Williams. Thank you for spending this time with me today. Your heart has been working every single minute of your life without ever once asking for anything in return. The least we can do is pay attention.